Good morning. Thank you for having me here today. I am excited to present my One Key Leadership Challenge, and it's a privilege to be a part of this fellowship program. And I'll take you through my journey here and where I am today. And again, my name is Shristi Liu. I'm part of the Presbyterian Healthcare Services in Albuquerque, New Mexico, and I'm in the inpatient acute care setting. And my current title is Executive Director of Nursing Practice. I was the nursing director when I was first initiated into this fellowship program. This new title has also helped me with my key leadership challenge, so I'm privileged again to be selected for this role and take us through this journey. The key leadership challenge that I selected was related to creating access in our community. New Mexico is considered a rural state, and access to health care is challenged, as evidenced by high ED hold hours. In fact, just at our location, our ED hold hours were averaging about 2,500 hours a week, which is significant and historically high. So patient flow became quickly a topic and a priority for us. And being at Presbyterian since 2007, I've had the privilege of seeing patient flow from a nurse perspective, a nurse leader's perspective, and now from an executive director perspective, which also includes a new department, which includes case managers and social workers. So really this helped alleviate some of those challenges and help me move further along. And the key leadership challenge here, it wasn't just as simple as patient flow, but how do I gain alignment from different stakeholders? And the three main key stakeholders include the physicians, the nurses, and of course the case managers. And our biggest challenge was making sure there's a shared accountability. And nursing had done some projects with early mobility to help patient flow, and our case managers were struggling with some stability. And right now, while we have that stability, our really biggest challenge was how do we get our physician partners at the table to have the same vision and share the same accountability model. We started off by using two of the roles that are under my purview, which is the flow coordinator role and the house supervisor role, and preparing some data and seeing where we are current state. And through that, we identified top 3 barriers, and one of them was delays in discharge because family was unable to pick them up in a timely manner. Granted, they cannot drop everything and be here at 5 p.m. or prior to 5 p.m. to pick up their loved ones. And how do we get a day ahead? And really, discharge planning should not start 2 hours prior to the order. It should be the day before, so we can order oxygen, necessary walker, and notify family that their loved one is getting discharged. So can we please make arrangements to have you be here? Well, the physicians plus all the other key stakeholders came together with an executive champion, which is our hospital executive, and had the support from her. And then process excellence got involved, and really the unbiased party here was the process excellence team, and really helped us align by saying, let's create an A3. What's your overall goal that will get us to increase capacity in the community? And ultimately was to decrease length of stay. And to do that, we need to identify patients who are medically ready to go. And physicians came up with the process, did some enhancements in our EMR, and now we have a list of patients who are medically ready to go. And then came our next challenge, was seeing or letting our physicians see that while the list is there, how do we coordinate care to act upon these patients' discharge planning? And it was really challenging to get here, but what I observed with process excellence, that Gemba walks are really helpful, and we had gained some success with our rehab team with it. So I went ahead and worked with our nursing leader who is overseeing flow and created a schedule for all stakeholders to go observe our multidisciplinary rounds to see if it lends to a successful discharge planning conversation. And that's where we are today. So hoping that now that we've created a medical readiness process where we know which patients are medically ready, how can we act upon those barriers and be a day ahead to really prevent our top barrier, which is families being here at bedside to take their loved ones home, and we're not waiting till 5 p.m. and beyond, and that those hours can be saved and given to our patients waiting in the ED. And this time there isn't a need for anything else except making sure that process excellence stays connected and being the unbiased party to help us with these challenges. I have grown significantly as a human being as a result of this fellowship program. With the new title and the Key Leadership Challenge, I feel that patience is the biggest thing I've learned. And I had said this when I first came to the conference when I was initiated into the program. Perspective is an important word. I know that everyone comes to the table with different perspective, and how do we align? And sometimes it requires a lot of patience, and some can get there from point A to point B quickly. But in this case, I had to really work with our physician group to see the reality with data, see that we're still not moving the mark, but here are some things we can do, and observing multidisciplinary rounds to see how those conversations really look like since they're not involved on the front lines directly. And that's where I'm at with my Key Leadership Challenge. I really do thank you all for listening and appreciate the opportunity to be here. Have a great day.
Hello, my name is Carrie McKenna Ducharme, and I am the Assistant Chief Nurse Officer for Presbyterian Hospital in Albuquerque, New Mexico. My facility is 450 beds and considered the mothership of a system of 9 hospitals across the state. We provide the most acute and broadest spectrum of specialties and services. Being the primary hospital, we are expected to set the standard for policies, procedure, and overall clinical practice. My direct reports include 7 nursing directors overseeing a specialty program each, such as women's, children's, critical care, and emergency services, to name a few. My Key Leadership Challenge was to engage the nursing director team in highly reliable, safer care and patient experience. Post-COVID, our care experience scores, quality results, and regulatory readiness all needed improvement. We have been experiencing high turnover rates, poor performance in our HCAP scores, and an overall drop in quality measures. The reason I chose this challenge was to focus on developing an engaged leadership team who would be connected to their purpose and reignite the reason they had chosen to be in healthcare. The goal would then be bringing the joy back to their work, allowing them to connect better with each other and their teams. With an engaged nursing leadership team, we would have an engaged workforce and expect results in lower turnover, overall safer care, and more consistent experience for our patients. However, to do this, I needed a goal and a plan that involved growth in both leadership and change management skills across all of our nursing directors. At the start of the project, Presbyterian HCAP scores were in the 34th percentile for Rate the Hospital year to date. This did not reflect the culture of Presbyterian or support the vision to lead the nation in high quality, exceptional patient care. So I decided to use the Rate Hospital score to be the measure of success and set the goal to achieve the 47th percentile by year end. I sought help and approval from the Vice President of Nursing. She presented an idea to develop leader standard work. The leader standard work would ensure that each director would role model key best practices to their staff, examples including rounding on patients, rounding on staff, and completing environmental assessments of each unit. During the Center for Creative Leadership course, I learned the importance of having direction, alignment, and commitment for all members of the care team. By developing leader standard work for my team, I was able to make connections of achieving the higher care experience scores to the organizational vision and provide an avenue for aligning all the nursing directors. I presented an initial plan to the directors, and they too agreed that the Rate Hospital score within the HCAPs was the right goal, and verbalized they felt responsible to help improve their employees' environment and the care provided at our hospital. I created a document where the daily work for the nursing directors was outlined from 0700 to 12 o'clock. I titled this, The Leader Standard Work for the Nursing Directors at Presbyterian. It included a component of even switching their schedules to evenings and weekends twice per month. Some of the steps and details I've included in the Director Standard Work included their day, participating in bedside shift report, and observing nursing staff making connections with their patients. During these interactions, the director is then expected to use appreciative coaching to provide feedback. In addition to staff observations, the director would conduct a leader huddle with their managers and assistant managers, and the remaining hours provided time for regulatory readiness activities and purposeful rounding on their staff. What I quickly identified is that we had some opportunities for improvement in our director's learning agility. First, I heard a lot of feedback that indicated their autonomy and their authority as leaders was being challenged, such as, I already do these things. Why do I have to do them at a certain time? How do you expect me to get my work done if you have already dictated half of my day? During this feedback, I spent time listening, validating their concerns, and explaining the rationale for standard work, reiterating the value of having direction, alignment, and commitment from all of us. I asked them to complete a few exercises to help manage their workload. One exercise I asked them to do was to evaluate all of their meetings. If the meeting that they conducted did not drive action, I then asked them to consider how valuable it was. Could they communicate that same information to their staff in a different way, or maybe even do a less frequent rotation of that meeting? At minimum, I asked them to move all remaining meetings to the afternoon, protecting their morning time to do the leader standard work. During a second exercise, I encouraged them to quantify feedback they were getting from their staff while rounding, identifying themes that they were hearing, and then using that as a foundation for where they should put their efforts. By continuing to highlight the benefits of alignment and commitment through the leader standard work, they were starting to come around. I also role modeled the same leader standard work and shared feedback during their daily director huddle. Currently, we are at the 35th percentile in the rate the hospital for year to date. Although we have not dramatically moved the year-to-date score, we have seen consistent week-over-week improvement for the past several months. Through further detailed assessment and review of our latest performance, we have identified the need for further alignment with the next level of our nursing leadership team. That includes nursing managers and assistant nurse managers for each unit. Yes, the directors are now seeing the benefit of their results and have the desire to continue to improve. Since each of the program directors oversees a slightly different patient population, it was important to allow some autonomy for them to create the leader standard work with their teams. I have asked them to complete this work by middle August. I have also continued to communicate our progress throughout the daily huddle, scorecards, and shared patient feedback, both for our opportunities for improvements and things that we are doing well. I am fortunate that our organization has now decided to partner with Press Ganey for a 2 to 5 year plan for improving the engagement of our workforce and patient experience. This will include education and training and practice for all members of the care team, including nurses, physicians, and allied health partners. This type of partnership will further my goal to help our hospital and provide a long-term sustainment plan. The Center for Creative Leadership has provided me the opportunity to examine my skills and think differently about how I can impact things as an assistant chief nurse. I have practiced the skills not only with my key leadership challenge, but in my approach to other projects as well. However, the most impactful thing for me is being part of the Emerging Leaders cohort. It is powerful and inspiring to be part of a group of leaders that want to deliver high quality care across the country. The different backgrounds and roles of my cohorts offers new way of thinking and new approaches to solutions for current challenges. During the course and my mentor meetings, I found my confidence growing. I realized I don't have to be great at everything, just willing to try. Remember to reach out to a friend or a colleague and to try skills or reinforce skills that I've already learned. I have grown in my capacity to analyze my team's performance and develop communication or set expectations that support an alignment to our goals. I am re-energized about my ability to make an impact not only in my facility, but in the nursing profession. I look forward to our future conferences and continuing my relationship with my cohort. I hope to implement many more projects this year and continue to enhance the services at my facility and how we serve our community. Thank you for your time and listening to my presentation.
Hi, everyone. I wish I could be seeing everyone live, but unfortunately, I can't be there live today. But I am very excited to share my key leadership challenge with all of you. So, my name is Katie Noss, and I'm the manager of clinical and quality improvement at the Pennsylvania Association of Community Health Centers, otherwise known as PAC. PAC is a statewide membership association for all of the federally qualified health centers statewide. Um, Otherwise known as FQHCs, otherwise known as community health centers. So you'll hear me talk about it that way through the presentation. Our health centers see all patients regardless of their ability to pay, so they really work to improve access to care and equity. So I'll start with a quote. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Dr. Martin Luther King Jr. I start with this quote because I feel like this really speaks to the mission of our health centers. As I said, they see all patients regardless of their ability to pay, and they provide primary care services as well as oftentimes dental services. And many times they are the only providers of dental services to Medicaid patients in our state. So, for my key leadership challenge, I decided to go with promoting access to dental or oral health care for uninsured, underinsured, and Medicaid patients in Pennsylvania. So, to give you some context, during the pandemic, many dental suites had to close due to infection control concerns. Many dental procedures are aerosol procedures, and therefore, with an airborne disease like COVID, they weren't able to be done. So, oftentimes they had to be closed, and staff were laid off, and this further exacerbated the already dental workforce diminished problem that we have in our state as it was. So. um, The workforce has been an issue, but also in 2011, Medicaid dental benefits were cut and have not been reinstated to date. So folks still have dental coverage, but it's very, very minimal and not meeting the needs of people. So why did I choose this KLC? Some dental suites who serve Medicaid patients have a 2-year long wait list for routine preventative appointments. And the average wait time to treat a cavity in Pennsylvania is 99 days, and this is just not acceptable. Also, statewide, there's only 23% of Pennsylvania dentists actually accept Medicaid, and most of those are community health centers. As I said before, in 2011, there was a major cut to the adult dental benefit for Medicaid to save $42 million. And now, if a Medicaid recipient would like to have something outside of routine care done, they have to go through this cumbersome process. And in fact, actually, less than 1% of those requests are approved. Pennsylvania is spending an average of $35 million annually for non-traumatic dental issues presenting in emergency departments. Many of these issues would not have occurred if people were getting the type of preventative care that they deserve. Dental workforce has been a major issue, has decreased 10% since 2015. And just to give an example of that, 55% of rural dentists are over 55 years of age. So, where am I at with my KLC? How is it going with getting access for Medicaid and underinsured folks in Pennsylvania for oral health? Over the last several months, I've been advocating the PA State Congress. You see a picture of us there on the Capitol steps at Oral Health Advocacy Day. And as a result of our efforts, on April 20th, 2023, a co-sponsorship memo was issued for restoring dental coverage for Medicaid assistance recipients. So this was very, very exciting and a first step in the right direction. Unfortunately, one of the co-sponsors for that memo has since resigned. So there will be a special election in September to fill her seat, and we'll see where things go from there, but we'll continue our advocacy. I've been promoting dental workforce and dental medical integration to make sure that there's enough access to providers for folks seeking oral health care. And I've promoted minimally invasive caries management through provider education. There's something called silver diamine fluoride, which is kind of on the cutting edge of treatment, oral health treatment, and public health dentistry because it's cheaper and more accessible. So, what do I need to do next? I need to continue to advocate for that HCO 1659, restore the Medicaid benefit. I need to continue to work collaboratively with our partner organizations to promote oral health and expand access to dental workforce as well. And continue to educate all the providers, medical and dental, about how they can help folks with their oral health. How have I grown as a human being as a result of the Fellows Program? I want to take the opportunity to say how thankful I am for the relationships that I've developed with all of the Nurse Trust Fellows, the great work of the Center for Creative Leadership in putting together our online modules, and the Nurse Trust for their organization and vision of this program. But most of all, I'm really thankful for the relationship that I have developed with my mentor. I have so appreciated the time getting to know Warren and learn from his unique perspective. My biggest takeaway has been that just being good at the technical aspects of my job is not enough. And being a leader is about how you interact with others and really is about serving others. This is one of the reasons I actually think that nurses are so well positioned to be leaders. Everything we do is in service to others, and for most of us, it's the reason that we chose this profession. So, for most of my career, I've placed an emphasis on perfecting the technical aspects of my job, but this opportunity really allowed me to focus on the soft skills necessary for leadership. Communication, self awareness, providing feedback, having vision, inspiring, and influencing others are just some examples of those things. And at the end of the day, being a leader is not about being in charge, but it's about using my skill set to pour into others and help them to succeed. It truly is a privilege. So I'll leave you with one more quote. We rise by lifting others. And thank you all for this opportunity.
Hi, my name is Katie Erickson, and this is my Nurse Trust Key Leadership Challenge video. So again, Katie Erickson, I am with Multi-Care Health System here at Tacoma General Hospital in Tacoma, Washington. I am the nurse manager of the neonatal intensive care unit. I have worked here in this unit for 21 years. I did bedside nursing for about 13 and then got my IBCLC, which is my lactation certification. Also did some program development work at that time, and then went into leadership about 6 years ago and have been the nurse manager for 2. My key leadership challenge that I chose is really to take a leadership role in merging the NICU under Mary Bridge Children's Hospital, which is the pediatric hospital in our system. So Mary Bridge is currently co-located in the same building as Tacoma General Hospital, and the merge involves collaborating and networking with other key stakeholders in the organization to ensure streamlined communication between team members so that decisions are made safely and accurately. And really, I'm trying to think of this key leadership challenge as really more an amazing opportunity. This whole merge is just a fantastic thing for our organization and our community and our patients. So I'm really grateful to be able to contribute to this. So since the merge into a new hospital affects so many people, it is really imperative that we communicate and work well together to ensure that important pieces of information are not missed. The merge itself includes approximately 250 employees that work in the NICU, and stakeholders across the system include legal and regulatory, EPIC and IS&T, Women and Newborn Care Service Line, pharmacy, quality, revenue and payer contracts, human potential, finance, safety and facilities, emergency preparedness, respiratory therapy, and a whole bunch of other teams that also provide support. And really the challenge has been or lies in ensuring that all critical pieces of the merge are addressed while simultaneously building lasting, trusting relationships with new team members. So to be fully transparent, I didn't really think that the merge to Mary Bridge would be a good key leadership challenge in the beginning. I wasn't 100% sure if this was what I wanted to choose, but I'm really glad I did because it's proving to be definitely more challenging than I initially thought. It is something I'm very deeply invested in, and really involves so many critical aspects of growth and leadership. And I think maybe a bit naively more than I thought. So the merge is really challenging me to think on a larger scale about long-term outcomes, building collaborative relationships with others, and how to gain confidence as a leader who really consistently demonstrates clear communication and self-awareness in my interactions. We are currently dealing with the intensifying reality of how this is all going to come together, especially as it relates to Epic workflows and builds. The go live date is set for October 2nd, and new pieces of information that impact nursing and physician process are still being communicated and worked on as we speak. In addition, there are human potential implications with the go live date as it falls in the middle of a pay period. So we may need some service level agreements in place to prevent co-location issues. Currently, what's happening in the most newest situation we are needing to plan for is that the NICU nurses currently provide support to the women and newborn nurses for neonatal lab draws, PIV starts, and heel sticks. And these are tasks that we recently found out will need to be done by the Tacoma General Hospital staff, either women and newborn team or the IV therapy team, to avoid co-location issues. So our educators will need to produce a formal education plan so that the TD teams can take over that current practice to ensure a smooth, safe transition for our patients. And then we're also currently reworking some Epic workflows and have just brought in a new medical director this week. So there's lots of changes currently happening, and we're really getting down to crunch time with our merge date. So how have I grown? I really never imagined that I would have the amount of personal growth that I have over the last few months. The fellowship program has given me a level of self-confidence that I really didn't have before, and I am finding my voice and realizing that I think I'm more valuable and knowledgeable than I previously thought. Being a part of the fellowship has not only given me this confidence, but also made me realize that I am needed in my organization more than ever to be a catalyst for change, for transformational leadership, and to establish the highest standards of care related to quality and patient safety. These are just things I'm very passionate about and am finding that I really love and think I am good at. So I'm really just grateful for the opportunity to contribute to the nursing profession and my organization on a whole. And I'm grateful for the people I have met through NurseTRUST, both my mentors and my other fellows. And as a human, I have developed more of a growth mindset and feel drawn to learning new ways to grow myself and those I lead. I am interested in how to become the best version of myself, both professionally and personally. I am set to graduate with my master's in nursing leadership next spring, and I'm so excited for what the future holds. So thank you for this once-in-a-lifetime opportunity, and I'm so proud to be a new NurseTRUST member. Thank you.
Hello, my name is Casey Dunaway. I'm an adult gerontology acute care nurse practitioner at the University of Alabama Health Services Foundation, which is a part of the University of Alabama at Birmingham Health System and UAB Medicine. Collectively, I have worked at UAB for 14 years, and I'm very proud of the institution I serve. I currently work at a satellite clinic in otolaryngology and facial plastics in Hoover, Alabama, about a half an hour away from the main UAB campus. And if I may, I would like to take a moment to highlight that our otolaryngology department's efforts have recently been recognized and nationally ranked on the U.S. News and World Report rankings as 15th in the nation, which is a testament to our dedication and commitment. On the otolaryngology service, I am one on a team of 10 nurse practitioners and PAs. I run an independent clinic Monday through Thursday and see up to 60 to 70 patients a week independently, in addition to working one day a week with our facial plastic surgeon. I recently received approval from the Alabama Boards of Medicine and Nursing and Medicine to begin training for minor procedures which include flexible fiber optic diagnostic laryngoscopy and stroboscopy, flexible nasopharyngoscopy, and flexible and rigid diagnostic nasal endoscopy, which has been a wonderful opportunity of growth for me to expand my practice and operate at the top of my scope as a nurse practitioner. I am a newcomer to the otolaryngology service and decided to focus my key leadership challenge on learning how to lead a team by improving team culture and dynamics. I have been on my team for a little less than 1 year. It was a hard decision for me to leave my previous team working on the inpatient lung transplant service at UAB, and it has been a huge transition for me. Although the lung transplant team had its challenges, mutual respect and teamwork were top-notch. Providers supported each other, transcending individual boundaries to create an environment of mutual support and respect. Having worked in various medical environments, I've come to understand the value of effective teamwork. In my short time in the otolaryngology department, I have realized the challenges we face as a team. While I may be a newcomer to this group, I'm familiar with the power of collective effort and transformative potential of unity and teamwork. In the past year, the otolaryngology department has witnessed the departure of 3 APP colleagues. The reasons for leaving consistently revolved around a common set of issues: a heavy caseload, handling complex patient cases, navigating unpredictable schedules, and grappling with professional dissatisfaction. This caused discourse between work and professional life, ultimately impacting the quality of patient care and diminishing job satisfaction. I've listened closely to my current colleagues and discovered that there is frustration in the inequity of APP scheduling, allowing some to have lighter schedules focused on specific diagnoses and others with a heavy patient caseload with varying complicated diagnoses. Knowing this, my key leadership challenge is to improve the culture and dynamics of our team of APPs to deliver exceptional patient care while maintaining a balanced personal and professional life. Reflecting on my experience with the key leadership challenge within the Center for Creative Leadership Frontline Leader Impact Program, one important lesson I learned was exploring the core of an issue to effectively resolve it. This concept mirrors the process of identifying the root cause of a problem, enabling us to implement sustainable solutions. For instance, in our discussions, we explore the significance of clear direction and shared objectives. In the Frontline Leader Impact Program, we learned that aligning core values to create a meaningful vision statement creates context so that others can understand the big picture and feel motivated in their professional endeavors. Our group needs to work on direction and staying committed in our goal of excellent patient care in a way that is not rushed, but maintains efficiency and is meaningful to the individual. Our team is considering implementing a productivity model based on relative value units, RVUs, in the upcoming years. This approach has the potential to foster a sense of direction among APPs and set clear, measurable targets for achieving specific RVU levels. What is unclear is how it will affect job satisfaction. In the Frontline Leader Impact Program, we also discussed the role of team alignment. We discussed that there's alignment when team members communicate and involve others in their work. They see the bigger picture of how their work connects with the work of others. While we largely have the aligning goal of ensuring patients receive optimal care, there are instances where personal motivations might overshadow this collective goal. For example, the desire to work quickly to finish early. A goal-oriented RVU care system may or may not boost individual productivity. It is questionable if this will allow each APP to efficiently contribute while still maintaining the opportunity to conclude work on time. A helpful tool for my key leadership challenge is the Meisner Nurse Practitioner Job Satisfaction Scale, designed to quantitatively measure factors influencing job contentment. This would be beneficial in determining if RVU-based care positively or negatively impacts job satisfaction, sense of direction, and meaningful care among APPs. I would like to administer the survey before and 1 year after implementing RVU-based care. To enhance understanding, I also suggest opening discussions with our current APPs independently from performance reviews. My wonderful mentor, Melinda Earle, and I discussed asking current employees what would make them want to stay in their current role. These conversations will provide valuable insights into each APP's perspective, allowing the discovery of what each APP values in their workplace. This has potential to uncover the sources of their job satisfaction or even dissatisfaction, and will enable the opportunity to address them before the employee decides to leave. For example, if an employee values equity of patient caseload and complexity, there may be a need to take an in-depth look at how patients are allocated or triaged. I'm excited to take what I've learned from the NurseTRUST E3 fellowship and use my knowledge to highlight myself as a leader in my new role. I'm confident that showing my leadership skills as a clinician will propel my career and lead me to discover new opportunities for professional growth and success. The Frontline Leader Impact Program by CCL was very methodical and strategically encouraged me to organize my vision for myself as a healthcare leader. My wonderful mentor, Melinda Earle, provided insight throughout the past several months that has helped me to realize my potential. I shared with her some of my strengths and my weaknesses as a leader, or at least what I thought was a weakness. She showed me ways to shape my weaknesses into strengths. For example, I'm an introvert. We had a long discussion in one of our meetings about the power of an introvert, not the weakness. I always ended our meetings feeling empowered, encouraged, and inspired. I look forward to my future as a healthcare leader in my community, at my institution, and with the NurseTRUST Foundation. I had a wonderful experience, and I'm so excited to welcome the oncoming cohort and hope to have an opportunity to share my experience with them. Thank you so much.
Hi, my name is Binsa, and I'm a senior epidemiologist at the Bureau of Assessment and Evaluation within Arizona Department of Health Services. Today, I'm happy to share my journey as a NurseTRUST fellow, guided by the expertise of my mentor, Dr. Mary Lodi Leon Science. This journey has led me to new heights in both my professional and personal realms. First of all, I would like to appreciate the opportunity for me to be part of the fellowship this year. And I also really want to thank my mentor for her tremendous support and encouragement and invaluable insights that she shared that have contributed to my growth. So my primary leadership challenge was to establish and implement a comprehensive surveillance system for adverse child experiences, or called ACEs, and positive child experiences, PCs, right here in Arizona. So this required close collaboration with a diverse array of stakeholders, including other public health agencies, local organizations, and university partners. So one strategy was centered around the dissemination of data insights from based on population-based survey findings. Beyond data, I also look for ways to improve policies, supporting trauma-informed care and assistance for children and families impacted by ACEs. I also look for ways to collaborate with researchers to conduct ACEs studies, contributing to effective strategies for addressing childhood adversity. Why did I choose this key leadership challenge? Arizona is 44 out of 51 for the percentages of children ages 0 to 17 years that experience 2 or more ACEs. So ACEs could be anywhere from parental divorce or parental loss, or living with someone who has alcohol abuse or drug abuse problems or mental illness. So 20% of Arizona children ages 0 to 17 years have experienced 2 or more ACEs, and 57% of Arizona adolescents have experienced 2 or more ACEs. And 4 out of 10 Arizona adolescents reported poor mental health in 2021. However, Arizona is one of 13 states that have not enacted ACEs-related legislation, and there is a great need for a surveillance system that captures both ACEs and protective factors, such as positive childhood experiences, that triangulate the youth's mental health issues related to childhood adversity. Where am I now with the key leadership challenge? So thanks to the collaboration with the partners and also the insights and the mentorships that I got from my mentor, I was able to develop surveillance documents that outline the best practices for ACEs surveillance, which is made available to the public now. And I published the ACEs website under Arizona Department of Health Services, including public-facing surveillance dashboards using various population-based survey data. And I created 3 infographics on topics related to youth mental health in collaboration with partners. So I'm hoping to use this information with other communities for community outreach, and also increase the awareness of ACEs and mental health issues. And I submitted a CDC grant proposal with external partners to improve the data to action ACEs prevention efforts in the state. And I presented surveillance findings on ACEs and adolescent mental health at conferences. And these are still ongoing projects. So I'm co-developing a full surveillance report on Arizona adolescent mental health, and that includes ACEs. And I'm collaborating with a local university partner on policy analysis to examine existing policies in Arizona and other states aimed at mitigating the impacts of childhood adversity. And I'm developing manuscripts on ACEs and mental health issues with partners for journal publications. So this is the website. You can scan the QR code to access the website. And you can see the definition of ACEs or the PCEs and state plans to mitigate ACEs and surveillance dashboards, reports, and presentations that were presented at conferences before. And this is one of several surveillance dashboards that we have. And this dashboard shows the prevalence rates of individual ACEs, and you can see the prevalence rates by demographics and the relationships with health status and family and other school-related indicators. And these are infographics that were published recently. You can scan the QR code to access the Arizona Youth Risk Behavior Survey website to see all these infographics. So these are more digestible for the public, easily digestible for the public, and I'm hoping to use this infographics for community outreach and increase the public understanding of these issues. And what do I need next? I would like to continue dissemination efforts to share surveillance findings locally, regionally, and nationally. And I would like to connect with more people who share a similar interest in advocating for trauma-informed care policies for ACE-affected children and families. And I would like to collaborate with partners on innovative ACE studies for impactful public health strategies. And my growth as a result of the Fellows Program, there are many areas that I saw growth in the past few months. I really appreciate about all the experience that I had. But if I need to choose top 3 areas, these are the top 3 areas that I saw the most growth. So the first one is I was able to increase self-awareness through self-reflection. And working closely with my mentor has really broadened my perspectives. So exposure to her experience and advice has really enabled me to see beyond immediate challenges and really look at, envision long-term goals. So expanded vision is definitely one area. And the last one is the learning and inspiration from diverse peers. This is something that I wasn't able to get from other fellowship program, but really wanted to, the fact that I was able to connect with other nurses from diverse background really enriched this experience. So I really appreciate that. And thank you so much for listening.
Hey everyone, and welcome to my presentation about the NurseTRUST inaugural Emerging Leader Fellowship Program, and this is my final presentation. As part of the final presentation, we need to talk about who we are, what our key leadership challenge is, what we identified, how did we choose this, and why did we choose this, and really then talking about where are we now with that key leadership challenge. Then identifying what we need to do next, and then certainly last but not least, how have we grown as a result of this examination? So who am I? I am Angie Raber, and I'm currently employed at the University of Portland, which is located in Portland, Oregon. Coming into this program, I was the BSN program director and have since let that go. But this year I also got tenure, so now I'm an associate professor. After our time in Louisiana, we were asked as part of this program to identify our key leadership challenge. So that was the thing that we would focus on for the remainder of the program. And as we got into this fellowship, I got this incredible surprise, which was that we had the opportunity to move from our home in Portland, Oregon, all the way across the world, down here to Southeast Asia, to Singapore. So if you've been to Singapore, come visit again. And if you haven't been, please come visit. We would love to host you. It's an incredible place. And I know that we just feel so fortunate to be here. The other was COVID, which I know we all experienced, but I think those of us in healthcare have been hit hardest. And the traditional tools that I have used as a leader weren't really serving me well. And so I needed to better understand how to lead during these times, and I needed new tools and I needed help. So that drove me to seek out this leadership and seek out more opportunities to develop my skills. So after some incredible conversations with my mentor, Suzanne Boyle, she really helped me put the words to this, which was that my KLC is really focusing on life transitions. And I'm so grateful for her helping me gain that insight. So as we moved through the fellowship, we then completed the Center for Creative Leadership 6 modules on key areas to examine our KLC, but just our leadership style as a whole, and just pick up every rock to really understand where are areas of strength and where are we really challenged. And this helped me identify 3 key areas that I really needed to hone or have needed to hone. And that first one is, what drives me? What is my purpose and meaning? I think those have been changed or augmented because of these experiences. How can I be more strategic? I don't know about you, but as a nurse, we're constantly pulled into things, and those opportunities often derail our own growth and in leadership. So I took some time to reflect and may have got a little distracted along the way, but I got back to that reflection, which really helped me drive where I need to go after this experience with the fellowship. And the first one is I need to do some reading. And the first thing that I want to start with, which I have started with, I've read Start With Why, Simon Sinek. But I have some activities that I'm going to do, I think that'll really help me hone that. Then just thinking and reflecting and journaling are important bits. And then this last part is something that cannot be underutilized, but I think it is hard for all of us. And that is just working with colleagues, taking time to work with colleagues. So how have I grown as a result of this fellowship? Just taking the time to look inside and gain more insight has been huge. And that has helped me add more tools to my toolbox, which is going to help me be more strategic and hone those skills. And then the last thing is that cannot underestimate the power of a team. We need each other, and that is critical. And we can only get places with each other. So my last words are that we are just better together. And I'm so grateful for all of you in this fellowship. And I look forward to connecting with everyone over the trajectory of our careers. Thank you.
Hello, I'm Jin Lin, an associate professor from Michigan State University College of Nursing. I'm holding the leadership position of the PhD program assistant director and undergraduate research program coordinator. So my key leadership challenges are about the undergraduate research program and PhD program. For the undergraduate research program, the key challenges are about the low enrollment and low diversity. In the past 4 years, the program enrolled about 10 students and 9 faculty each year. Most faculty were in the 10-year track. and only 18% of the students were ethnic racial minorities. For the PhD program, the key leadership challenges are also about low enrollment, as well as challenges in the BSN to PhD track. On average, we have only about 1 to 3 students each year, with most students being international students with full funding from their own country. About 50% of the BSN to PhD students are struggling due to insufficient preparation on research and statistics during their BSN program. As a result, they either dropped out of the program or moved to a part-time program in their year one. Why I chose these as my key leadership challenges. The first 3 reasons are about our university mission and our college vision on conducting research and developing knowledge, as well as our college values in diversity, equity, and inclusion. The other 2 reasons are driven by the nursing faculty and nurse researcher shortages. U.S. nursing schools turned away more than 90,000 qualified applicants from nursing schools in 2021. Most nursing schools pointed to nursing faculty shortages as a top reason for not accepting all qualified applicants into their program. Since PhD program enrollment began to dip in 2013, enrollment in these programs have decreased by 13%, from 5,000 students in 2013 to about 4,000 students in 2021. So there is a shortage of nurse researchers, and because of baby boomers retiring, less than 5% of the nurses in the US have PhDs. Where I am with the key challenges. For the undergraduate research program in 2023 to 2024, we doubled the enrollment with 15 faculty and 21 students. What I did include gaining financial support from administrators, the dean and associate deans, working closely with our DI assistant dean to connect to the Access program, and advocating and communicating the program to faculty and students according to their values and goals. For the PhD program, it is still ongoing. We have remote DIE as a requirement, developed a part-time program, conducted faculty mentoring training, submitted an NIH R25 grant for supporting a BSN to PhD bridge program, and added multiple options for the graduate level stats requirement. To collect data to support our actions, we have conducted 2 needs assessments to determine interest in a research-related certificate and interest in participating in nursing research. First, we surveyed 156 clinical nurses to assess their interest in taking graduate-level online courses, including statistics, research methods, and literature review, resulting in a certificate. We found that 42% were interested in taking this type of coursework, and 55% were interested in pursuing either a PhD or DNP degree. Second, a survey was conducted with our clinical partners at Henry Ford Health to assess the educational preferences of the nursing staff. A total of 200 nurses responded. 70% worked in the inpatient setting. 38% indicated that they were interested in participating in nursing research. Our next goal is to increase faculty grant funding to support more graduate assistants. Next steps, I have 2 goals. One is collaborating with the College Communication and Marketing Office to develop an undergraduate research program video to promote student recruitment. The other is working with the PhD program director and PhD program committee to develop a hybrid or online PhD program. My growth due to this fellowship program, I had the great opportunity to study and analyze my key leadership challenges, build self-awareness of my strengths and weaknesses through completing surveys and reflections, improve effective communication including nonverbal communication that I have missed before, improve skills on influencing others through championing initiatives and neutralizing resistance, became comfortable with embracing organizational politics and managing upward, increased conflict management skills, and connected with other wonderful fellows and mentors. Most importantly, my confidence in leadership increased. Thank you. Go green, go white.
Hello, my name is Emily Norris. I am a practice manager within Corewell Health in West Michigan. I currently oversee general surgery, gastroenterology, and endoscopy. So I am here today to talk about my key leadership challenge. And for my KLC, I chose to implement the DAISY and B awards in all of our ambulatory sites. Being that I work in Corewell Health West and it's a very large system, this type of initiative really impacts thousands of staff members in our system across ambulatory, and we have hundreds of different sites, which means we have hundreds of different leaders that we really need to have buy-in from. So this was no easy feat. Just in case anyone doesn't know, I want to make sure to define what the DAISY and B awards are. The DAISY award is founded by the DAISY Foundation and was created by the family of Patrick Barnes, who died of ITP in 1999. And they created this foundation to recognize and award nurses who provide incredible care to their patients and to really say thank you to the nurses that provided them incredible care while they were inpatient. The B award, which stands for Being Excellent Every Day, is something that we plan to initiate within Corewell Health. And it is really, aimed at any non-nursing personnel. So it could be an NT, an MA, it could be our lab, it could be radiology, or it could be a non-clinical team member. Our hope is to really encompass all of our team members in Corewell Health with this recognition program. So in order to do this, I partnered with our senior operations specialist. Her name's Ashley. She's amazing. She's very tech savvy and has worked with other award programs in the past. So I figured she'd be the perfect person to help me with this project. To start, we socialized this idea on a ambulatory practice manager meeting, which again had hundreds of leaders on this call. And there was just an overwhelming amount of positivity and great feedback that they were really excited that this could be coming to our ambulatory sites. So that solidified our work for us, and we really kind of took off from there. We started meeting every week. We started developing standard work. What does good look like? What do we want this process to really ultimately to do, and what do we want it to look like? So we created an operational toolkit for all of the managers. We created a web page. We designed marketing materials and had to really engage with, the east side of the state as well as, the west, to make sure we were in alignment with what their recognition programs were. So just a lot of work went into this, and it's been months. I really kind of took off with this right after our conference in the spring. So where we are right now, actually, we just presented at the August ambulatory practice manager meeting and announced that we are open and ready for nominations to recognize our team members. So I'm really excited about that. It just feels really great to have made such progress in this initiative. We, again, in that meeting, just kind of walked through with the managers, what are your first steps? What should you do to get this off the ground in your site? So a lot of encouragement is going to continue to go out to leaders, because we really, in order to make this a successful program, we need buy-in from hundreds of leaders to get this, off the ground. So that's where we are now, and our next steps are truly just to continue the encouragement to leaders, to continue our socialization efforts to get this out in front of people, to make sure that they understand just how important this award could really be to our team members. I chose this for my KLC because I'm very passionate about recognition. I have a passion and a love for people, and I really like to make sure people feel like they're seen by their leadership, they're appreciated, and everybody likes to be appreciated a little bit differently. And so I think that this has just an incredible amount of potential to make staff members feel that appreciation. And when we make our staff members feel fulfilled, I think that has downstream effects such as increased retention, decreased turnover percentages. We've got, potentially increased and improved patient care and increased productivity and efficiencies. So I'm just really excited to see where this program can go. The last thing I want to talk about is how I've grown since I got into the NurseTRUST Fellowship Program. And first and foremost, I think 100 times over, I need to thank Erin Denholm because she's the most amazing mentor. And I'm so thankful that I was paired up with her in this process because she has, I mean, there's something to say about somebody who just radiates positivity and you can feel it and it makes you feel positive too. And I think all of the passion and energy she put into helping me grow as a leader was inspiring, and it makes me want to help to do that for somebody else too. So I can't say enough about her. We met every single week, and her, our mentor meetings were always somewhere between 30 to 45 minutes, and she always focused on, what do you need as a leader? What can I do to help you grow? And I just think that I have grown so much in a short period of time because of her. So thank you, Erin. I also really enjoyed the 6-week program from the Center for Creative Leadership. I thought that was really nice, and it helped me learn a lot about myself as a leader that I wasn't really taking the time to think about before. Took a lot of notes, printed a lot of slides. I think those are things that I'll look back at for years to come in my career. And then Mary Kay Vandriel, if it weren't for her, I definitely would not be in this program. And I think because of her, hopefully Corewell Health is going to continue this program in the future and nominate emerging leaders into this program. I have learned an incredible amount, not only about others and how we can impact the general population as nurses, which is incredibly inspiring, but I've also learned a lot about myself, which is, I think, one of the biggest things for me that I had as a takeaway from this program. And I learned a lot about what I can do for other people, so I'm really excited about that. So I am hoping to continue my KLC for years and make sure that our teams feel recognized, and I can truly say that is an outcome because of this NurseTRUST Fellowship. So thank you so much.
Hello, my name is Donna Hyde. I am the interim director in the School of Nursing and Population Health at the University of New England in Portland, Maine. The focus is looking at the skills that students are doing in the clinical setting. What can they and what can they not be doing while they're in certain facilities? Boards of nursing do not determine what those skills are. Academic programs do the best that they can to try and anticipate what skills are necessary in the clinical setting. And sometimes the facilities themselves will determine very specific areas that students cannot do. Nursing students are in multiple settings, so there's different types of experiential rotations. Each facility seems to have variations on what is allowed or not allowed. And the clinical instructor often determines what skills are acceptable for their shift based on either their own personal level of understanding or comfort with certain nursing interventions or what they perceive as acceptable to that unit or facility. So my aim is to get the support and the buy-in from our major clinical partners, healthcare organizations, to determine whether or not we can have some established guidelines and policies that could be developed to provide a greater level of consistency for all students involved in these settings. This would also help to promote student satisfaction as well as nursing staff or employee satisfaction working with students. What we found is that the facilities staff are also confused, uncertain what certain nursing students can do, what certain schools will allow. And so this creates sometimes a level of hostility within the units or staff not necessarily being excited to take students. So perhaps having more of guidelines, more of an outline of what is possible on those units, who's allowed to do what and not do certain things would be beneficial for everyone involved. So my goal is, once this is established, to also bring in other schools of nursing because we want shared information. We want patient safety. So this continuity will really help all around. So where am I now? So we've had meetings with key healthcare organizations. Those have occurred and those have been very productive. It's been wonderful to have the buy-in and positivity from those healthcare organizations wanting the same thing, really having more of an established guideline that everyone can follow, with certain specifications that are unit specific, but overall really determining what we can do because their sense is they do want to see students doing more than less tasks on the units. This will help them prepare for once they graduate, be ready to go and feel more comfortable in those settings. So we've established a working document that we're all able to access to do revisions, suggestions, and that's gone really well. They, again, have had their interest in this because it is, a satisfaction for really both sides of the equation. I've received competency-based orientation tools which outline what each new nurse in their specific facility would have to follow. And so that helps us also identify what we're teaching here from an academic program. The clinical facilities, our partners, are also discussing and working with their legal counsel when we're looking at these different edits and suggestions as to whether or not there's any legal issues that we need to consider moving forward. So, this is not something that happens overnight. It does take some time, and I understand that, but I'm also very excited at the prospect that they are on board and really looking forward to working with us to really establish some sort of policy and procedure that we as the University of New England nursing program can also share with our academic universities, other schools of nursing, this information so that maybe we can all collaborate and be close to the same types of information. which really will help in that clinical setting. So more meetings are needed, so it's very difficult to get all key players in high positions together, but we're so far so good. We need confirmation as to whether or not the nursing staff on those units, not the instructor, could also provide oversight to interventions and tasks if the instructor is not available. That's another area that's very widely different in different facilities. Some places allow that, some do not. We know it occurs in some places and others not at all. So again, that continuity would be really helpful. And that, from our end, we are also looking at liability and coverage. So should something happen with a student, with a nurse who is not our instructor. So there's all kinds of little, I guess not so little, but areas that we need to consider and come to a consensus on whether or not we're comfortable with that. Once this happens, meeting with the smaller healthcare organizations to collaborate with the policy regarding student nursing skills in those settings, and refining our own skills labs in the classrooms so that we're making sure we are focusing on those priority skills for the new graduates. And how have I grown? When I started this process, I was an associate director of the experiential education, so I oversaw all of the clinical placements in community settings, as well as teaching courses. And in the middle of this, I transitioned into the interim director role, and this really shifted my focus a lot on what I was doing, as I was a leader in many ways in the areas that I worked on, but this was something entirely different. I was now in a position where I was overseeing all of the faculty and staff. I've definitely been a firm believer in that people do the job they are supposed to do. And the fellows program really taught me how to see myself as a leader, or how am I as a leader? What do people respond best to? How do they respond to me? What do they need from me? What are their preferences? It wasn't really always something I thought of. I had a good relationship with folks, and I thought I got along with people, but really looking at it from what do they need versus how do I respond to them. Having crucial conversations, not really the best time of my life, but realized that by sitting down and meeting with people and having those conversations really left me feeling very positive and proud of myself to be able to do that. And instead of skirting around an issue, really telling them, how I felt and what I'd like to see moving forward. And I think the biggest part of growth for me, has been a gain in my confidence, which acknowledges what others saw in me that I didn't always see in myself or couldn't quite understand in myself. But this certainly has changed my perspective. I'm very glad that I did this, and it really has helped me tremendously, and I look forward to continuing growth. So thank you very much, and I appreciate your time.
Hi, my name's Angela McConaughey. I am the director at Goldfarb School of Nursing. I have 2 undergraduate options, an accelerated program, which is 3 terms, and then a weekend evening option, which is 9 terms or 3 years. So my key learning challenge is related around roles and responsibilities. When we were at the NurseTRUST conference, we were going through quite a bit of change. New roles were created. Some people had left and their roles weren't replaced. So I thought it was a really key opportunity for me to be able to look at the leadership aspects of what is the current structure, what's the organizational chart, what are some roles and responsibility, and ways that we can better monitor that. So the purpose of the presentation is to go over, why, which I already explained a little bit of, kind of changes ahead, and then where I currently am, what's next for me, and then how this has helped and guided me in my leadership journey. So a little bit more about the why. The changes that we've currently had over the last little over a year, we have had a new president. We have had our entire president council has turned over. Our dean left about 6 or 7 months ago. We now have an interim dean who's only here for a year. And we've had quite a bit of turnover. We're also in some fiscal dilemmas, and so with positions and rehiring positions, combining positions, kind of what that looks like. So we knew that there would be a lot of changes related to some positions and roles and responsibilities. And then there were some positions that were created prior to COVID. Kind of see where one began, one ended, to feel it out. Never really came to fruition about what the differences were in those roles. So this can help a little bit with that. In the bottom left, you'll see that it's an example of how I started. We started writing down everything that we did. There's several positions, just kind of jot down everything that you do. And then I took it to a few key groups. So what do you think the assistant dean should do, the director, the dean? How can we help you better in your environment and with your role? And so I have some different colored sticky notes there. And then we worked together on this as a group, but we started to look at what's some of the timing. Do we do these things every day? Do we do them once a term? Some things we just do once a year. And then what area of our job is that? We do teaching, scholarship, service, and then as a leadership team, we also have added in the student aspect, the faculty aspect, and of course the leadership. So we categorize them based on that. And then additionally, we looked at how do you do that? So if that is something that you list as something that you have to do, where is that document that you update? Who do you communicate about that? Is there a structure or procedure when you do that, that certain aspect of your job? And then overall, a communication structure. That's the part that we have not done yet. But if there's 3 or 4 of us, we don't all need to be in the same meeting. So there needs to be a communication structure where one of us maybe can go to each meeting, and then we can come back and talk about what happened, talk about procedures, new rollout, some launches, how we can help, and things like that. So all of us don't need to be everywhere, and kind of looking at what that communication structure is, so we don't feel like we're missing something if we're not there. So that's kind of my key leadership challenge. We're at the communication part right now. Our new dean has been here for about 4 weeks, and so she has taken this document into consideration when she's looking at redoing the roles and responsibilities of positions. So it's been helpful in that way. How this has helped and guided me, it has really helped me look at overall positions, descriptions, strategic planning, organizational charts, who does what. There's a lot of things that change when processes are added. So let's say you have a launch of a new product. There might be a heavy lift at first as you're getting things organized and rolled out. But if there's maybe a technology piece, then that might be very helpful to some positions. And instead of eliminating those, is there a way we can look at restructuring that position or job description? I mentioned that we did have some positions that are not being filled. And so if we only have this for my group right now, but if we had this with more positions, then when that position's being eliminated, this would be a real clear example of what does that position do on a daily, term, yearly basis that will allow us to distribute that workload more adequately and appropriately to others, or to support the fact that we really do need to keep that position where it currently is. So it's been interesting. It's been challenging overall, but I think it does help me realize that change is always happening. So you do have to be flexible. You have to go with the flow, but if you know your stuff and you know your information, then that plan can run much smoother. So doing some pre-work can really help with the process and the rollout of that change. So I am currently, about 6.5 minutes, and I don't think I have anything else to add. So this has been really interesting, making sure that I have all the right people at the table, and hopefully it'll be able to roll out to other departments for organization and succession planning. Thanks, everybody. Have a great day.
Hi, my name is Katie Jett, and I'm from Goldfarb School of Nursing at Barnes-Jewish College in St. Louis, Missouri, and I will be speaking today about my key leadership challenge, which was identifying barriers to student success, a DEI initiative in nursing education. And the focus will be on how I have been working to leverage the GSON, also known as Goldfarb School of Nursing's Culture Council, to do some baseline assessments. When I left New Orleans after our NurseTRUST conference, I had a really clear idea that was really worked over and vetted with my mentor, Dr. Angela Green, about how we could holistically support students of diverse backgrounds that were recruited and admitted to the college but struggled as they progressed through our programming. And while in New Orleans, had the pleasure of learning about the social determinants of learning and how they affect the learner. So I had a very, very, very clear goal when I came back, and I talked to my leaders about how we might begin to kind of look at this. And I knew that I wanted to include not only students, but really to do kind of an assessment of our leadership, our faculty, and our staff. Around the same time as my return from New Orleans, I was beginning to work with a newly formed group that were selected by our leaders to form GSON's Culture Council. And the goals of the Culture Council are listed on the slide, but they really are to develop and identify some foundational curriculum regarding DEI and civility for everybody at the college. And that, again, is inclusive of all the key stakeholders here listed on the slide. To develop, identify supplemental curriculum regarding DEI and civility for those that want to continue their journey, and then how to really embed our values, DEI and civility throughout the college. Well, we really got kicked off, and in May and June, we started to meet more frequently, about bi-weekly. And we were talking about different activities that we would do. We had pride activities. We had a variety of other things as well. And about that same time in June, we had, as most of us in higher education became pretty familiar with, was the SCOTUS ruling about the elimination of race-based criteria for college admission. Our group, our whole college, but our group, we're kind of waiting to see what would happen. We have been doing a lot of really targeted and pipelining and pathways to increase the diversity in our college so that it reflects the population and helps improve patient outcomes, which we've talked about a lot at the conference that we were at. Well, this was a big deal. The day the Supreme Court of the United States released that ruling, the Missouri's Attorney General, Andrew Bailey, released a statement that not only would admission criteria not be allowed based on race, but that colleges that utilized race-based kind of criteria for scholarships or financial aid, that could not continue. We were all like, wow. And the background on that is that in 2022, we partnered with Barnes-Jewish Corporation, Barnes-Jewish Hospital, to have full ride academic scholarships, full ride $60,000 plus in tuition for students. And there were 3 criteria for the scholarship: race, need, and GPA. And essentially, we had increased our enrollment of diverse students quite substantially. And I was intending to work on the student support, student success pieces, following this this implementation, and this set us back quite a bit, right? So immediately, our admissions team with leadership was like, how do we have to rework this? What do we have to do? And the University of Missouri St. Louis, which was one of our big programs, said that they would not have any more scholarships or financial aid based on race. And that was about 6.5% of their financial aid or scholarship budgeting. So you can see that's quite large. So we had to revise the scholarship, and our team was talking about this in council, and like, what do we do? How we know that in order to have the best patient care outcomes, we have to have a diverse population of nurses that reflects the population that they serve. And so, almost kind of serendipitous, we kind of took a step back and thought, how do we look at our own climate? How do we look at our own culture for its climate based on some of these things? And I'll talk about that a little bit on the next slide. So what our team decided to do, and it was supported and vetted by our president and dean, was really, and this is actually what I'll be leading with another, with our alumni member, to see, like, what is our current culture right here. And so we are going to be, we're in the process of structuring the rollout of the LAMP survey, which is a survey that's intended, it's called Learning Across Multidimensional Perspectives. It's a culture and climate survey. It's part of the AACNCEI toolkit with a focus on culture and climate. This was really designed to capture the feelings and experiences of underrepresented minorities in nursing programs, and the outcomes which is a huge driver, right? Success, practice, transition, passing the licensure exam, entering practice, etc. We'll be looking at how learning environments influence faculty and student experience and outcomes, adding on as well staff and leadership. And so the plan is in the fall, we'll begin having a step-by-step approach on how to begin to do the LAMP survey as a baseline assessment of our college to see where are we at, especially as the national dialogue about race, racism, inclusion, and belonging in academic nursing, recent legislative movements to kind of eliminate race-based admissions and diversity-based admissions. So we're going to be looking at that. I don't have any outcomes yet, but I am excited to say I am actually moving forward, and I'm doing so with a team that's going to start by assessing our own culture, our own climate here by employing the LAMP survey. So that's what I have at this time. Very excited to have such great mentorship and guidance through my mentors and our group and others as well. And I look forward to presenting in September and hopefully having an update about where we are related to our culture assessment. Thank you very much and have a great day.
Good morning, everyone. My name is Jordan Jacoby, and I thank you for joining and listening to my presentation on my Key Leadership Challenge. So I am at Touro University, and my Key Leadership Challenge for the purpose of this fellowship was a faculty development project. So as I indicated, this Key Leadership Challenge was on faculty development. I started at Touro about, I guess now 9 months ago, in January, and really discovered that there was not a lot of professional development for the faculty and orientation to the role of the academic nurse educator. And so this is really important because most of the faculty were very junior, a couple years into their nursing education career. And, even some of the faculty that I brought with me were not necessarily very senior into their nursing education career, with about 5 years of experience, which is certainly not anything to laugh at, so to speak. But it's still very early in one's academic career, especially in the setting of a lack of professional development and orientation to what is assessment and evaluation and curriculum development and all those things. So the length of the project was to be 6 months. And of course, the setting is an undergraduate school of nursing. And this is really important because the undergraduate program is also struggling in terms of its pass rates on the NCLEX RN. And so that faculty development piece, it was envisioned that that would then flow down to a benefit in students as the faculty become more acclimated to all of the different domains of nursing education. And so really this project helped the faculty see that being a nurse educator is more than just showing up, teaching a class, and going home. So this is a very important challenge because, as we all know, nurse faculty do not grow on trees. And there's a critical shortage of nursing faculty, particularly as many faculty in the next couple of years are going to be retiring. And then that change, or that shortage rather, is particularly acute here in New York City, which is an overall reflection of the superimposed acuity of the nursing shortage in New York City compared to the rest of the country, where it already is a known problem. And so really this key leadership challenge addressed what really, if we're honest, was a lack of investment in the faculty. And so that need for improved student outcomes that I briefly mentioned earlier in terms of the NCLEX pass rate really starts with the faculty. If you have a well-trained and well-prepared faculty who are really oriented to all of the domains of the role of a nurse educator, which is teaching, service, scholarship, and clinical practice, then you have better prepared students because the faculty are more oriented to all of the things that they must do. And so really this key leadership challenge then looked at assessment, evaluation, curriculum development, and really developing the faculty in terms of their nursing education piece. So really very focused in that teaching and that service domain so that we can improve student outcomes. So what we did is we formed several committees. We formed the Quality and Evaluation Committee, which looked at assessing and evaluating the performance of the program. So did students meet student learning outcomes? If not, why not? And in what areas did they not meet those student learning outcomes? And how effective were the teachers in teaching the students and in mentoring the students? We also developed a curriculum committee, which looked at the structural soundness of the curriculum and how it's being delivered. And so the major project was to begin work on aligning the curriculum with the AACN essentials from 2021, as well as competency-based education. And so as you can imagine, that piece of this project is going to be an ongoing effort in terms of aligning the curriculum to the essentials. And so neither of these committees previously existed. Also, we developed a leader in faculty mentorship, as well as a mentorship program between senior faculty and more junior faculty. And so we also required that faculty attend one nursing education conference and then one conference specific to his or her clinical specialty. And so then we also created regular faculty development days. There would be 3 per semester. And so the first couple development days, again, went back to what is program evaluation and what is the role of the faculty member in assessment and evaluation in the overall nursing program, and then how to do assessment evaluation related to his or her own course, as well as there was on curriculum development and what is the nurse faculty member's role in developing curriculum, both individually and in the setting of that committee. And as part of that mentorship between myself as the leader and the faculty member, I did encourage one faculty member to go for her certified nurse educator board certification with the National League of Nursing, which she attained. And one faculty member went on to pursue her certified healthcare simulation educator board certification. When I first recorded this video, I did not have an update but I now have the update that a faculty member has obtained her chassis certification. She's long been an experienced simulation educator, and so that mentorship really helped her lay that pathway to study for the exam, to pursue that goal, and to then pass the certification. She really just needed that encouragement in that investment from the institution that she'd be supported in obtaining that board certification. And so then the final piece of that was, as a faculty, we looked at what is active teaching and learning, and how do we teach the faculty and develop them to develop the students. So we taught them how to employ active teaching and learning strategies like role play, games, case studies, unfolding case studies in the classroom versus just traditional lecture. And so we did development seminars on how to incorporate those teaching techniques into their teaching practice. So what is needed now? This certainly is going to be an ongoing project, so continued investment in this key leadership challenge is essential. We will all have to continue learning together, and then I myself as the leader will need to continue developing in that way as well. And then collaboration both for myself with more senior leaders in academic nursing education, as well as collaboration with the faculty and continuing that mentorship program. So I really have grown because I've come to truly see my role even more than I did before as the guide on the side, to really be that coach who is cheering everyone on, and that motivator and that mentor, and the understanding that I have to identify what is important to my stakeholders and how to merge that with my overall vision for the program. And so it really has allowed me to have a renewed sense of motivation and meaning in this leadership journey, which thus far has certainly had a number of challenges thus far in my tenure here. But I think that this leadership fellowship has really made the experience that much more rewarding and has made me more introspective. So thank you for listening to my presentation, and I hope you enjoyed.
Hello, my name is Lana Sargent. I'm the Assistant Dean for Practice and Community Engagement. I'm going to be presenting an effort that I have been leading for the past year and a half. It's an evolving collaboration for advanced practice nurses, and it is our collaboration between the School of Nursing and the academic medical system. What we've been building and our goals in our collaboration have been about bridging the academic practice gap, which is easier said than done. Underneath in the framework of bridging this has been building a faculty practice model. We are now in our third year of that faculty practice model, and I have been leading these efforts for about a year and a half. And that includes everything from our advanced practice clinical education to individuals transitioning into practice, and then our faculty practice supporting a practice model itself, and that is advanced practice, everything from scholarship to seeing patients. We truly believe in this past year as a part of being the NurseTRUST. We actually collaborated on a shared faculty practice mission. And our mission is really to establish a sustained academic practice model that will enhance nursing profession through practice, teaching, and scholarship and service. So that's why this particular picture here, the bridging to academic practice, shows that the faculty practice model really is the basis to clinical education and the transition and sustained scholarship and practice. So in the first year of myself taking on this leadership role, we had to establish as a team some pillars of work that fit in with our strategic plan. There was a lot to do, as you can see. We have actually achieved the majority of these goals, but we had some really significant challenges under operations. And then we are still building out our teaching model, our faculty practice evaluation, our faculty practice scholarship model, and we have lots of opportunities for growth. However, the primary focus for me stepping into this role was operations. We really needed a strong framework in order to build the faculty practice model off of. So there was a lot of work to be done there. A quick overview of our faculty practice, and I'm just including the advanced practice. So these are our nurse practitioners and not our nurses, who are also a part of the faculty practice, just for the discussion today. So we have 24 full-time NPs, 19 of those engaged in clinical practice. That's about 75% of our NPs that are engaged in faculty practice, teaching, and scholarship. And we're in a variety of different settings. I do have 14 individuals in which are part of what we call our faculty practice model. And that was what we were building this past year and a half. That required infrastructure, workload support, financial infrastructure to support these individuals. And you can see they're in a variety of different settings, everything from outpatient to inpatient settings and community-based settings. And as you can imagine, all of these settings operate differently. They onboard individuals differently, and they're doing a variety of different patient care activities, as well as teaching and scholarship in all of these settings. So one of the key operational challenges that I had, and it was one of my key leadership challenges, was to identify a standardized process for onboarding our faculty. We didn't have a very good system. It wasn't seamless. It was quite complicated. The health system didn't really understand our role. We are hired by the university, but they're at the academic center. So we needed to really set up a financial structure, a clear system for onboarding and tracking of clinical care. So I worked closely with a number of key stakeholders. This was everyone from the health system business office operations for the financial structure to the HR onboarding and medical staff services. We also I had to work closely with collaborating physicians to identify physicians in which individuals would be onboarded with and their lead APPs in these settings. We did this in about 6 months and are currently testing the model now with our 3 new onboarding faculty practice individuals. But it took really a heavy lift with a lot of stakeholders involved in leading these efforts. Most recently, I did complete a SWOT analysis. This was an end-year review right before I started much of these efforts in 2023, and they still stand to this day of weaknesses and strengths in the area of what we've been building. We really found a genuine commitment and a passion to a program such as this for our faculty. There's a lot of value added for the teaching mission and patient care model, and it was very helpful in the recruitment of new faculty. One of the weaknesses we encountered was the onboarding process itself, and that right now is what I had turned into my key leadership initiative. That after doing the SWOT analysis at the end of 2022 really helped me lead into what we needed to focus on, and that was that inconsistent onboarding process, which we are currently testing out now. We finished the process, we have the framework, and now we're testing to make sure that it's working well. We are in the next year going to be working on in the evaluation metrics. So we have underdeveloped evaluation metrics of the faculty practice, and so we are currently working on those now. There's an enormous amount of opportunity. And again, this SWOT analysis came from those individuals working in the faculty practice and leadership themselves. So everyone identified that there was a great opportunity for growth in the number of educating APP students with our faculty, as well as scholarship that we could do in these settings. There is a threat. There's always a constant threat to new programs. And the 2 that were identified for us was really the lack of understanding regarding an academic faculty practice for nurses. It's very well known for physicians, but not very well known for nurses. And so kind of changing that culture shift. And then the health system has an implicit bias for education of medical students and residents that we are working through now. We have lots of works in progress. The idea is to continue to work on many pieces of what we've identified. The leadership skills that I've learned in the NurseTRUST will continue to help me build out the pillars of work that we've identified. I'm eternally grateful to my mentor, Dr. Kate Findon, who has enormous amounts of expertise and years of experience in faculty practice, and I truly enjoy working with her, and I've learned an enormous amount in building what we've been building in conjunction with the work that she's been doing. Throughout the program, I've become much more politically savvy, and the ability to kind of forecast change, especially within the health system and the university. And that forecasting change allows me to address conflict up front, and it allows me to align the team's work with a lot of the financial structure and environment that helps support this model. So I have to say I've truly enjoyed the experience and appreciate the opportunity. Thank you very much.
Good evening. My name is Alana Kavanaugh, and I am the Assistant Dean and Director of the Family Nurse Practitioner Program at the College of Mount St. Vincent in New York, New York. My key leadership challenge was surrounding improving graduation rates of nurse practitioners to allow them to complete the program on time using a remediation program. So tonight I'm going to speak about my challenge. So the background here, so nurses, of course, make up the largest workforce in healthcare. About 4.2 million nurses are in the workforce. 355,000 of them are nurse practitioners. And so we are constantly needing more nurses and more nurse practitioners in the workforce to build and support the need and the infrastructure. Applications for nurse practitioner programs, so qualified applicants are turned away from programs annually, and a downturn in applications in 2022 showed a reduction by about 7.3%. Enrollment, so graduate programs have seen a reduction by almost 10% from 21 to 22 in their enrollment in programs. So where are all these nurses going? And program completion. So program effectiveness is actually marked by attrition and timely completion in nurse practitioner programs. So it's not only important to allow nurse practitioners to get the education they need, get them into the programs, but also have them complete in a timely, effective manner so that they are ready to produce and provide care to the population they're serving. So my purpose statement here with my key leadership challenge is to using a pilot study was to improve or investigate the use of a student-centered remediation program in a graduate nurse practitioner program as a method to improve program completion rates and reduce attrition. The stakeholders involved were, of course, the students who had invested time and money into their program, the institution, which of course depends on revenue generated by the student's tuition, and it's ranked by student outcomes, such as things like, their board scores and attrition rates. And then administration, like myself. So it's held accountable for student outcomes, including attrition, program completion rates, and the admission of the candidates. And of course, the community, which is the larger nurses shortage, further exacerbated by lack of trained professionals, which we urgently need in nursing. So my sample, my inclusion criteria were students in the clinical phase of the program that were either unsuccessful in a previous course or had taken an extended leave of absence. They were all graduate level students, and they were all enrolled in a family nurse practitioner program. So my method. So the first thing I did was identify those students that were at risk. The second thing was I created a remediation contract, and that contract identified roles and responsibilities for both the mentor and the mentee involved in the remediation program. The third was faculty coaching. So there was weekly meetings scheduled with both faculty and students that were one-on-one to review the students' clinical notes. There was discussion about their differential diagnosis, their clinical management, their diagnostic reasonings. And there was a conclusion that the faculty were able to make about where the student was in the trajectory of their learning. And they were able to kind of customize the plan to allow them more one-to-one coaching or remediation. We also offered open labs, which help students with their skills. And so we brought the students into the lab with the faculty that they were remediating with, and we allowed them one-on-one coaching to go over, head-to-toe assessments, making a diagnosis, ordering tests, reading diagnostic materials and such. And then the fifth thing was to evaluate the outcomes. So collecting the data on the student success that were actually enrolled in the program. So here are some of the assessment tools that I utilized. Here again, the one-on-one weekly coaching. We used the Prime NP model to level where the student should be in the program and what the appropriateness was of their evaluation. Again, looking at the clinical cases and reviewing them with the faculty, and then the open labs here. This was the student self-evaluation and the evaluation form we used both at the formative and summative assessment point, which helped us also to identify those students at risk and enroll them in the program. And so students were able to use Benner's model, novice to expert, and score and rank themselves based on how they felt they performed. The faculty also scored them, as well as the preceptors that were seeing them in the clinical setting. So what happened? So in the spring of 2023, we had 4 students that were enrolled into this remediation one-on-one coaching. 2 of them actually were successful and 2 were not successful. So we had about a 50% success rate the first go around. In the summer of 2023, we did this again. We made some mild tweaks, which I'll talk about in the next slide. We had a total of 5 students enrolled, and actually 5 out of 5 passed, and we had a 100% success rate in that portion, which we're very excited about. So in conclusion, what we found is that a remediation structure can help students that were enrolled in an F&P program to reduce attrition rates and to help them move along in their journey to become nurses. What we learned was that we needed a standardized contract, and so the students that were in the first semester did not have a standardized contract and format, where we noticed that when there was a lack of standardization in the roles and responsibilities, as well as a planned agenda, that very often they would not keep the appointments. And so once we standardized that really helped to allow the student to be more successful with the mentor-mentee relationship. The initial assessment, again, is very important, as the faculty were able to decide what level they were at in the program using Benner's model, novice to expert, as well as the prime NP model, so that they could appropriately guide the student up to the level at which they needed to be proficient in. And then again, evaluation. So the remediation program can be successful. It's a low-cost intervention for NP programs that can improve program completion and reduce attrition rates. I really enjoyed getting to work with the Nurse Leadership Foundation here and working through this this program and getting to deal with this key leadership challenge. So thank you.